Good afternoon, everyone, and welcome to the Minnesota Autism Developmental Disabilities Monitoring Network data release. We are so happy to have you. I am Dr. Jennifer Hall-Lande. I'm a researcher at the Institute on Community Integration at the University of Minnesota. And I'm here today with my colleague, Dr. Amyessler, and we are going to share the data release of both the Autism Developmental Disabilities Monitoring Network national data as well as Minnesota data. So thank you again for everyone coming today, and we're excited to share these results with you. Next slide, please. So just a little bit of background before we get started. Last time we gathered together was March 2020. It was the beginning of the pandemic. It feels like a long time ago. That was our last ADM data release. And you may be noticing that this is actually December. Typically, we release in March. Today, the CDC is releasing at noon, right as we speak, new numbers. The methodology has changed and it's become faster. That was feedback they got from the network. And so we're sitting here today on December 2nd, sharing the results early. And today we're going to talk about, it's part one of an ongoing series, the national ADM data, as well as comparisons of Minnesota data. And these will just be broad comparisons today. Part two, and look for an invite in January, will be a deeper dive into the ADM data, looking more closely at Minnesota and specific Minnesota communities as well. So you're going to get a 2-for-1 this data release year. And on today, again, I'll be talking about national trends, and my colleague, Dr. Amyessler, will be sharing Minnesota trends today. Next slide, please. Previous one. Just a little bit of background, and I'll be using the term ADM a lot today, trying to be careful with my acronyms. ADM stands for the Autism Developmental Disabilities Monitoring Network. ADM is the largest ongoing tracking system for autism in the United States. It really has an incredible legacy, almost 20 years of data collection in communities in the United States. And we always think about the prevalence, the overall numbers, but it really has told us many things about our communities. One, it's described the population of children with autism in many communities across the United States. It also compares how common autism is in different parts of the country. It provides valuable information on the age of identification. One thing we'll talk about today, we know the earlier we get to children with early interventions and supports, the better their life outcomes. And ADM has been a valuable tracking tool in helping us understand when we're identifying children. And then to identify trends in autism over time. Next slide, please. So here's a map, which I find interesting. It is the Autism Developmental Disabilities Monitoring, the ADM network sites. And again, I'm going to be talking about surveillance year 2018. This is 2021, but we have, there's a gap between the actual years the data is collected and when we report it. So you may hear me saying study year 2018. But in study year 2018, there were 11 sites across the country. Luckily, Minnesota was one, why we're here today. And you're seeing here with the purple and turquoise stars, the sites that have tracking among 4- and 8-year-olds in their states, as well as some states also have 16-year-olds. I think it's interesting because we often get the question, are there ADM networks in every state? No, it is a select cross-section of states within the US, 11 right now, and we hope we're able to grow. Next slide, please. Thank you. And then this is a bit of a map here that shows within those states. Arkansas, one of the states, used to collect the whole state, but most of the states collect within high population density areas. You see Minnesota on here that we collect in Minneapolis, St. Paul. These are select areas when this is a public health study at its core. And so they really need large data sets, denominators. And so they go to highly populated areas. That is definitely a limitation, but that's something so you can sort of conceptualize how and where the data was collected. Next slide, please. Previous slide, thanks. A little bit about our methodology. So one thing we're going to be talking about today, one of the reasons we have had a faster response time is the methodology did change. I'm going to give you a broad overview of it very quickly, but a couple strengths of the current ADAM methodology when we look at it nationally and within Minnesota. We look in both schools and clinics. So we know that we get the most representative sample. We get a look at the most children if we are collecting data both in educational settings and clinical settings. So that's step one. Step two, we have trained data abstractors that go out in the field. They review the records and collect diagnostic and eligibility data. Step three, we have scientists and epidemiologists analyze the data. And step four is what we are doing today, is sharing our data with the community so they can use it in their work in many, many different ways. And we'll talk about that at the end. One thing I want to clarify about step two that is different if you look at some of the notes, we are now using an autism case definition. And what we use is documentation of a written ASD diagnosis by a professional or a special educational eligibility of autism, or an ASD ICD code, which stands for the International Classification of Diseases. And so those are the three that we look for, and it has helped us get a sense of what prevalence rates look like in our communities. Next slide, please. You'll be hearing me say a lot about prevalence today. It's a very simplified slide. And so our numerator will be the number of 8 and actually 4-year-olds. We've brought 4-year-olds in, number of 8 and 4-year-olds with autism over our denominator. We use census data over the total number of 8 and 4-year-olds, and that is how we calculate prevalence. Next slide. So today I am going to be presenting the national data from the Centers for Disease Control and Prevention. If you go to their website, you will see they have just within the last few minutes released their data. Up until now, it was embargoed. So we are reporting concurrently along with them. And so the basic question of this project is, the first question, what is the prevalence of autism for 8-year-old children in select communities in the US? Next slide. So what you'll see on the CDC website and what we're reporting today is rates are nationally in US communities within the ADAM network, 1 in 44. 8-year-old children were identified with autism in the ADAM network. That's about 2.3%. And I'll show you how that compares to previous years. Next slide. So as we look at this chart, we look at study year 2000, when CDC first started collecting data in select US communities, and we're seeing rates of 1 in 150. And what we're seeing is in each of the 2-year data cycles, steadily increases. You may be comparing, which most people would, 2018, our current study year we're reporting on today, with 2016. And we're seeing that in 2018, the numbers compared to the previous year do look higher. There's likely a couple reasons for that. One is the change in methodology. Number two is it's not necessarily looking at the same communities. So it's interesting to look across time, but we also need to be careful with that as well. Next slide. One reason when we say that it looks different, we're seeing here a bar graph, and you're seeing within the ADAM network, which the 11 sites, we see that California has the highest rates. They're approximately at 1 in 26. So that certainly changes what national numbers look like. New Jersey second, and Minnesota is third. Missouri, that collects primarily clinical data, has lower prevalence, and we're sort of seeing a reflection there that sites that can combine both their education and clinical, we're able to capture more kids and bring more kids in. Next slide. This is the same bar graph I had before, but I think it's interesting when we look across the ways we bring kids in and count. We're seeing, again, this is the same one, California, New Jersey, Minnesota. Minnesota, we have a relatively robust number of kids that we brought in under special education eligibility. I think we'll see this theme throughout, that in Minnesota, it really is a testimony to the critical role that schools play in autism identification and providing services. So Minnesota looks very good in terms of that. Next slide, please. Another piece of data that the ADDM network has consistently given us is the numbers on gender. So what we're seeing, and this number has been relatively consistent over time in the national data, boys were 4.2 times more likely to be identified with autism than girls. We definitely get a lot of questions about this. We are basically counting what we see, but definitely it is a point of discussion. It has been highly consistent within the ADDM network, and we're seeing that ratio again in other autism research. Certainly, it opens the discussion, how do we make sure we're giving girls equal access? But right now, and we can look at the Minnesota numbers a little bit later as well, this is the number that we have in terms of gender breakdown. Next slide, please. Another piece of data that the ADDM network continues to follow is, this is a box and whisker plot. It's not the most exciting, it's a CDC table, but are we equally reaching kids from different racial and ethnic groups? And what we're seeing when ADDM first started collecting this data, there were disparities or discrepancies across groups. If you look at this plot, we're not seeing those disparities across racial and ethnic groups in terms of autism identification. We're still seeing it in terms of the sex gender breakdown, but there has been progress made in US communities around that. Still much more work to be done, but these numbers do reflect some progress in that area. Next slide. Another major contribution of the national ADDM data, we know that the characteristics, or what we're seeing in our population of children and adults with autism, is that it's changing over time. And what we see is the majority of children, at least as we look at 8-year-olds, about 65% have an IQ greater than 70. We're seeing 35% have IQ less than or equal to 70, or what we consider a co-occurring intellectual disability. ADDM has told us that's been a change over time. And as we think about implications for services and supports, this is a very valuable piece of data to have. Next slide, please. When we look at this by gender and race and ethnicity, we're seeing, and this was a little bit of a surprising finding, the male female, we're seeing about equal in terms of the co-occurring intellectual disabilities. So these are children, 8-year-old children with autism that also have a co-occurring intellectual disability. So that actually, we're seeing relatively similar numbers on that. Where we are seeing something that's a little concerning is we looked across white, Black, and Hispanic. We use census categories, and what we're seeing is higher rates of autism and co-occurring intellectual disability with Black children. And so we definitely need to look closer at that number and understand it better. And really understand, are we getting to kids early enough? Are we helping them? Are we supporting them? How can we understand that better and make a difference in that area? Next slide, please. Oops. So our secondary question, and Minnesota has just started, this was our first study year where we actively collected 4-year-old data, and we're excited to share it. Some other pilot sites have been doing that for a while. A fun piece of ADDM history, when ADDM first started, they chose 8-year-olds because they felt that would be the youngest they could go to get peak prevalence. If we started ADDM today, we probably would go younger, but this is a step in better understanding what autism looks like in our younger group of children. Next slide, please. Okay. So what we are seeing on this one, again, Minnesota had the second highest in terms of 4-year-old. Again, if you look at the blue here, and I think that's interesting, these are the states that collected 4-year-old data. Again, California is far and away higher. But what we're seeing in Minnesota is, again, a very robust contribution from our special education eligibility. Our schools are really doing a good job, and we're continuing to improve and work, but they're making significant contributions in terms of our population of children who are 4 years old that get an autism special education eligibility. Ours is almost 50%, right? I think it is around 50%. Compare that to other sites that are primarily clinical. Next slide, please. So what we have for a number, not to be confused with our overall 8-year-olds number, we had a 1 in 59 number for 4-year-old children in US community. So this is the national number, or 1.7%. Next slide, please. And again, something that is very important to me that ADDM tracks, again, we know from the research, it is sound. The earlier we get to children and their families with intervention, the better their life outcomes. And so we look closely at the median age of clinical diagnosis. And what we're seeing at a national level is 50 months or 4 years, 2 months. We do know that autism can be reliably diagnosed around 2 years of age with clinicians with special training. And so we know we need to continue to work on that number. And of the children identified with autism, we see that under 50% had an evaluation in their records by 36 months. So certainly we've seen improvement in that area, but we continue to want to focus and bring that age of identification down even lower. All right, next slide, please. All right, and with that, I am going to turn the PowerPoint over to my colleague, Dr. Amyessler. Amy, are you ready to go ahead and share about our MinADDM data?
Yes, absolutely. Thank you. Yes, I'm Amy Essler. I'm an associate professor in pediatrics at the University of Minnesota. And I'm going to tell you about the Minnesota specific data that we've gathered so far. And to give you a little history, the Minnesota ADDM project rose out of quite a collaboration of individuals. The interest in autism prevalence in Minnesota started in the mid-2000s when there were parent reports of high numbers of Somali children attending Minneapolis public school preschool programs designed for children with autism. And it was really a grassroots effort where some parents advocated at the federal level to come and look at this phenomenon. The first step in this progression was that the Minnesota Department of Health devoted some funds and looked at the prevalence of autism in Minneapolis preschool programs and the racial and ethnic breakdown there. And they did find higher numbers of Somali children than expected in some years, but not all of the years. So that study kind of raised more questions than it answered. Through continued advocacy at the National Institutes of Health and other federal levels, we were able to apply for and get funds from the CDC, the National Institutes of Health, and Autism Speaks to do a study specific to Minneapolis on autism prevalence with an eye toward prevalence among Somali children. That study did not find a higher prevalence rate of autism, but it did find unexpectedly low rates for Asian, Hmong children and American Indian children. In 2015, we applied to formally join the CDC ADDM network, and we were awarded funding to join, and then that was renewed in 2019. In 2019, as Jen just went through, we were also able to look at prevalence of 4-year-olds for the first time. Okay. There. Our goals in Minnesota are to estimate prevalence specific to Minnesota, and we are covering parts of the counties of Anoka, Hennepin, and Ramsey. We also, besides just counting cases, we identify characteristics of children with autism, including race, ethnicity, whether co-occurring diagnoses are present, and also look at differences in when children are identified across different demographic categories. A big purpose of our work is to share the findings of project data back to the community and back to our leaders in the state to advocate or to inform policy that improves services for children with autism and intellectual disability in their communities. So that's one important way our data can be used. So we collected health and education data, as Dr. Hall-Lande noted. And so we had these portions of Hennepin, Ramsey, and Anoka counties where we tracked prevalence, including the city of Minneapolis. So we look in the health records for various billing codes from the ICD-9 or ICD-10, that's the International Classification of Diseases. And then we also look in educational records for special education codes. And those were requested from our participating school districts as well as health sources in our surveillance area. So we take those records and we narrow it down to children who are ages 4 or 8 in the study year 2018 and who had a parent or guardian who lived in the surveillance area. We also collect that demographic information on the child's sex, race, and ethnicity. Today, we're focusing on the main CDC race ethnicity categories of white non-Hispanic, Black non-Hispanic, Asian and Pacific Islander, and Hispanic. But we also collected data on language spoken in the home. And early in 2022, we'll present that data where we look specifically at Somali and Hmong children. Okay, so starting with 8-year-old children in Minnesota. In our surveillance area, our 3 counties, we had a total of 10,081 8-year-olds. And this is showing our denominator, so the number of overall children in our areas we were looking at. And the percents give a breakdown of the race ethnicity of those children. So we're just over half white non-Hispanic. And here are our prevalence numbers. So based on this study year 2018, 1 in 36 8-year-old children in Minnesota was identified with autism. And that's about 2.8% of the population. This percentage is higher than the overall ADAM network prevalence of 1 in 44. And it is also higher than our prevalence from 2016, looking at the year 2016, which was 1 in 44 also. Okay. Here is the information broken down by race and ethnicity. So we did see some differences this year in Minnesota, with Black children showing a higher prevalence rate compared to Hispanic children and non-Hispanic white children. White, Hispanic, and Asian children did not have a detectable difference in their prevalence compared to one another. I want to give a caveat, though, that these prevalence estimates all differ from one group to another, but sample sizes were pretty small for some of the groups, especially Asian children. So if you look at the confidence intervals, you can see that some of the groups have a wide estimate, like the Asian group, which was 13.6 to 33.7. And that means that their estimate is less precise because we had smaller sample sizes. What a 95% confidence interval is, it kind of means that if we did the study 100 times, 95 times, the ASD prevalence rate would fall somewhere between that range. So 95% of the time, the overall prevalence would fall somewhere between 24.5 and 30.9 children per 1,000 children. So we want to emphasize that we should use some caution before drawing a lot of conclusions about any differences between groups, because we have small numbers in some of them. We're always working to expand our surveillance area, our study area, to include more children. And so having larger sample sizes to work with may allow us to determine if there's true differences here that either we have not been able to detect, or if the differences we haven't detected are because there aren't any differences there. Like the ADAM-wide network, we saw a higher rate of autism among males compared to females. That's consistent with ADAM-wide estimates and with previous Minnesota estimates. And just recall that these data reflect autism rates based on who was diagnosed or identified with autism in our Minnesota communities. It's been a pretty consistent finding to have about 4 boys for every 1 girl identified. And so the overall rate in Minnesota for boys is 1 in 23, and for girls, it's 1 in 100. We had information on our intelligence quotient IQ data for 81% of our children that we looked at. children with ASD. And within that group, 29% of identified children with ASD had intellectual disability, which ADAM defines as an IQ less than or equal to 70. And another 71% had an IQ higher than that. Okay. Our median age of clinical diagnosis of autism was pretty high. We know, again, autism can be identified at age 2 years very reliably, but we are seeing with our median age of diagnosis that about half of children were not diagnosed with ASD until after the age of 5 years, 3 months. Remember that the ADAM-wide median was 4 years, 2 months. Our median age of identification or diagnosis is later than that of all other sites within the ADAM network. And our last estimate had us at 4 years, 9 months. We can't directly compare those medians because the methodology changed, but we do have the latest median age of diagnosis across all 11 sites. This is probably the hardest news that we have to share today, given the many ongoing efforts to reduce age of identification in Minnesota. But I will have a slide in a second that provides a little bit more context. Of the children identified with ASD, only 45% had a recorded evaluation by 36 months of age. Okay, now looking at 4-year-old children. So we had a similar sample size within the 4-year-old, so 10,529 children total that were 4 years old in our study area. And you can see the racial ethnic backgrounds are similar here again. And the prevalence among 4-year-olds is 1 in 44 in Minnesota, or about 2.3%. We don't show it on this slide, but we had a slightly lower male-female ratio in the 4-year-old group with 3.3 males for every 1 female identified. And that is a prevalence of 1 in 29 boys and 1 in 100 females. And looking at this broken down by race ethnicity, we again see some differences in prevalence. In our 4-year-old group, Black children had a higher prevalence than white children, and Asian children also had a higher prevalence than white children. Same caveats apply here. You can see that our group sizes for Asian and Hispanic children especially are low, which means that their prevalence estimates are less precise. And that's also reflected in the confidence intervals. So these results really need to be interpreted with caution. Again, we are seeing the statistics bear out that the prevalence is higher for Black and Asian children compared to white children. But, this is sort of caution for now. Again, we need to increase our sample sizes to see if these are stable results. Our 4-year-old data can tell us a little bit more about how early we're identifying children in Minnesota. So a few slides ago, I mentioned our median age of diagnosis was really high or late, and this slide offers a slightly different perspective and some evidence that our early identification efforts are working. These graphs show something called cumulative incidence, which is the rate at which we are identifying children with autism over time. So if you look at the 4-year-olds who are in the yellow/orange color, we can see that there's a steeper slope, which means a faster rate of getting identified prior to 48 months of age, where that line is. And it's a steeper slope compared to the 8-year-old group. So we found that 4-year-olds were identified at almost twice the rate, so 1.8 times the rate of 8-year-olds, meaning early identification could be increasing over time. So our study has some limitations, particularly in Minnesota, where we have smaller numbers compared to looking at ADAM-wide. We did expand our geographic area to include parts of Anoka County this year, which was great, but we still want to emphasize that the findings reflect a small number of children concentrated in our largest metropolitan area. It's often the case that prevalence estimates are higher in a concentrated metropolitan area compared to like a statewide estimate. Often there are more services available, greater access to services, which, now that we're looking at autism by identifying who's been identified, that can make a difference. We did find varying prevalence rates across race and ethnic groups in Minnesota. But again, the small number of children in some of the groups warrants caution in drawing conclusions. We hope to expand our geographic area to have more reliable and stable estimates in the future. But for the moment, we know that wherever these differences are found, whatever these numbers mean, it's important to focus on the general health disparities and the general implications of what these numbers mean. And how our state agencies and us as community members and citizens can use this information to get more supports for children and families with autism. You'll also notice that we did not present numbers today specific to our Hmong and Somali communities. We have the data and we just haven't examined them carefully yet. So we're looking forward to sharing that information with you in 2022. So we can't yet say from the data today whether Somali or Hmong children have a higher or lower prevalence compared to other groups. I'd say the biggest implication from our study today is that we are identifying autism later than other states and much later than recommended. And so that's concerning given what we know about the importance of early intervention. Our next steps with this work is we're going to continue our work. We are in the middle of collecting data for study year 2020, which should be interesting because that's our pandemic year. And we're continuing to look at prevalence for 4-year-olds and 8-year-olds. We'll have a slightly different array of school districts involved in the 2020 data, but we are still in parts of Anoka, Ramsey, and Hennepin counties. And our charge as the Minnesota wing of ADDM is to really study the characteristics and prevalence of children with autism from Somali and Hmong communities. And we're also interested in comparing age of identification in health and education settings. And with that, I'm going to turn it back over to Dr. Hall-Lande to further discuss implications.
Thank you, Dr. Essler. I appreciate you sharing all the Minnesota data. It's very interesting. All right, well, now we're pivoting back to me, and I'm going to talk about some of the applications and uses for the data. People sometimes say, why do you count? Why do we keep counting? And what we say is numbers matter. ADDM data over 20 years has been a powerful advocacy tool. It has told us that autism really no longer is a low incidence disability. When we see numbers like nationally 1 in 44 and 1 in 36, it means most of us, if not all of us, know a child with autism, know an adult with autism. And so it's helpful. It's helpful in terms of advocating. It's helpful in terms of understanding both numbers, but how it's changed over time. And so a couple things when people say, what can we do with this data? And Annika, you had a great question and I will answer it as I go. We really want to use this data to inform policy. We understand this data tells us many things about children with autism in this population. What they need, what support needs, how many children we're expecting. It really is very effective when you start with policymakers. They like personal stories, but they also like numbers. And this really is a very, very helpful tool. We also know from the ADDM network, the data both nationally and certainly in Minnesota, while we've made some gains, and there's a lot of good work going on in our state around early identification, we need to keep working. When we are looking to see such a late age of identification clinically in our state, we need to work with pediatricians, healthcare providers. Are we getting kids identified in these well baby visits? Are they getting referred to clinics Are the waiting lists manageable enough that kids can get in quickly? We need to continue, and this is really a cross-agency, interdisciplinary effort. It's not just medicine, it's not just education, it's not just clinically. We all need to work together to lower that age. Another piece we know, looking at these numbers, we're going to need more providers and supports for children and families. I have several of our LEN fellows on here today. The LEN program, and I won't speak in acronyms, stands for Leadership, Education, and Neurodevelopmental Disabilities. I know many of you have done a LEN fellowship here today. And what really we're doing is training the next generation of leaders in the fields, as well as to build capacity through an interdisciplinary lens. And frankly, we need more of that. The need right now is far outweighing our capacity. We also need to look beyond 8-year-olds and 4-year-olds. Honestly, we spend most of our life in adulthood. These children were 8-year-olds when we collected the data. They're moving into adolescence, and soon they will be transition age and then adults. And they're coming into a service and support system that has a significant shortage. We need to continue to do better and continue to build capacity in that area. Next slide, please. Hopefully it'll move. Again, and I just spoke to this. One thing I do want to say is we look at those numbers nationally. One of the hypothesized reasons that California is seeing a higher prevalence as well as a much earlier age of identification is they've put a lot of resource into early identification around diagnostic, treatment, early intervention. And in our state, in Minnesota, we need to do the same. Again, as I said before, we're looking at workforce and provider shortages. We really need to diversify our workforce so our workforce looks like our children that are coming through. There's just many opportunities in that area. Again, things like the LEN Fellowship Program, several things our state agencies are doing, but we really need all hands on deck to really build up this workforce capacity. And certainly, as we think about our next data collection year, that will reflect some of the impacts of COVID. We know COVID has been pretty hard on our workforce as well. So we look forward to continuing to problem solve around this. It really is a significant need. Next slide, please. So as I said before, as we are speaking and sharing, CDC has released their national data on their website. So we wanted our partners to be the first to hear it from us, but you are more than welcome. We encourage all of you to go to the ADDM website and look at their 2021 community report. It is very well done. It's a wonderful overview of the ADDM network, of trends over time, of what it looks like nationally, as well as in specific communities. I strongly encourage you. And Annika, you asked, how can we share this? This has some wonderful infographics, as well as other pieces. And certainly our team will be developing as well some tools for you to use for advocacy. But this is a wonderful report and a great place to start to really get a national snapshot of the data. Next slide, please. Also, at the end this afternoon, we will be updating our website, our MinADM website, the Minnesota version. We encourage all of you to visit this website and take a look. It does a bit more of a deeper dive and also connects with resources in our state. So I would encourage you to look, if you have your afternoon free, to go to the national website, take a look, and then take a look at our ADDM data. It certainly should be up by tomorrow. We are scrambling. The CDC will tell us with a few days notice that we are reporting these numbers. So we are working as fast as we can. But if you go to the CDC website, you'll see theirs, and then ours should be updated very soon. Next slide, please. I would be remiss if I didn't acknowledge all the wonderful work going on in our state, both around building capacity around autism, our workforce, providing early intervention services and supports. The Minnesota Autism Resource Portal is a wonderful resource. It has been worked on very hard by our state agencies, and I encourage you to check this out and follow up with that. We're lucky in our state. We really have a wealth of resources, and we just want to share. Next slide, please. And again, this is a pathways document. It's in postcard form. What we hear from families consistently, actually what we hear all over the country, is it's hard to navigate it. It's hard for families. It's a complex system. Many of us work in it and it's complicated. I'll just speak for myself. It's complicated for me. Many of these tools have been developed. I know a lot of good work is going on with the Minnesota Interagency Autism Committee to say, how do we connect the dots across state agencies and work together in harmony so it's easier for parents, but also how do we help parents navigate this system? I think this pathways document is particularly helpful. And if you look at it, there's links within so a family can understand how to navigate the system a little easier. Next slide, please. Another Autism Navigator, which is, and this is their related First Words project, has been implemented in several school districts with their, I believe their Part C programs and possibly Part B. And that is a training program where we work alongside parents and help with early identification of autism and help with things like building language skills, early social interaction skills. It's a wonderful program. Many school districts are involved, and that is through Minnesota Department of Education. All right, next slide, please. Many of you have seen these videos, but I wanted to mention because it was a partnership between ICI and DHS, Minnesota DHS, Department of Human Services, and it was telling family stories about early identification and early intervention across 5 communities. I believe it was 5. They're in families' home language, so we have Spanish, Somali, Hmong, we have African American families, American Indian, Native American, all telling their stories. You can look this up online about early identification, their journey through early autism identification, and how to access supports and services. Not only do we have family stories, but we have professionals from each of those communities as well talking about it. I encourage you to check that out. And so for those of you who work with children and families, they're wonderful resources. Next slide, please. Of course, I would be remiss if I did not mention another CDC public health project. Learn the Signs Act Early is a project that's working very hard to help bring children and families in for early developmental screening, early intervention, and giving children and families the support they need early on. I encourage you to take a look at the free Milestone Tracker app. It's an app to use on your phone. It is free. There are no advertisements. It is really meant just to support parents through developmental milestones. It has developmentally appropriate intervention activities. It has discussion questions before a well child visit. It has resources for how to follow up. And it provides a wonderful sort of background looking back in terms of what the child's developmental trajectory was. It is a wonderful resource, and it's in English and Spanish, and I encourage you to check it out. It's another tool we use to help with early identification. Next slide, please. These are the books. Many of you have seen them. Another Learn the Signs Act Early. These are storybooks. They are free. They're free. They are the 11 or the 7 county metro area. You can get them through Help Me Grow. If you're in greater Minnesota, I certainly, you can contact me afterwards. These are wonderful books that a parent can read with their child. They're free, they're colorful, they're beautiful. They talk about developmental milestones and how you can support development, and also another link to how, if there are concerns, how can you act early and get the support you need. Next slide. Another Learn the Signs Act Early. It's a brochure. We've made these into posters. Really, you can get these materials for free, and they all support our efforts for early identification. Next slide. And we just wanted to give some credit to our CDC partners. You can also look up these reports online. It is where we got our data for 8-year-olds and 4-year-olds. Minnesota helps contribute since we are an ADDM site. And if you really want to do a deep dive through the lens of research, you are welcome to take a look at these as well. They are now available. Next slide. And of course, We wanted to acknowledge and thank our partners, the CDC, our state agencies, and all of our clinical and educational data partners. We couldn't do this study without your support. And we very much appreciate your ongoing support as well as being here today. So thank you so much. We appreciate it. And you really are helping to contribute to a very important data set. So thank you. And also I want to acknowledge our team. We have a great team here working hard out in the fields, and I'm doing what we're doing today, sharing, and I appreciate all of their work to bring this to you. Next slide. So that brings us to the end. Again, we hope this was interesting. This will be posted on our website for later viewing. Again, I also encourage you to follow up and look at the CDC community report, as well as look at our website. But now we have a little bit of time left and we can answer some questions. I want to make sure I fully answer. The first one I saw was Annika's about how do you promote this? Do we have social media tools and infographics? Yes, this is a very quick turnaround and we will be working on that. That's very important to get the word out. The more people that know, the better. We consider this data to be Minnesota's data, and we want it to be of use to you. So yes, please email us. There's also a MinAdam email, and I'm wondering if Libby can put that in the chat. So that maybe she already has. I can't see the chat right now. And we are happy to provide you with anything you need to help with your work. Thanks for the question. And Dr. Essler, I'm going to take a look. But it sounds
I can answer the next question from Allie Wilson. That's a great question, Ellie. Her question is, can your team help connect the dots related to higher prevalence among Black and Asian children? In most of our experience, Black children are under-recognized, under-identified. How do we kind of explain that? You're right, Ellie. In the past, traditionally, we have been finding lower autism prevalence for Black children and Hispanic children especially. We haven't always had the numbers to look specifically at Asian children. And I think what we're seeing in the ADAM-wide network is that we are reducing the disparities in identification. In Minnesota in particular, our data can't tell us necessarily why these differences are present. We're only able to just say what the numbers are. When we've talked about this with our CDC colleagues, one hypothesis is that we're catching up in identifying Black and Hispanic children, and that's maybe part of the reason for the higher prevalence that we see this year and last year too. So we'll have to sort of gather different kinds of evidence to look at the why of that. But I hope that what we can take from it is that we are getting better at reducing disparities. And we probably had more Black and Asian children to catch up on identifying, given just the history of under-identification. Jen, I can also take the question from Anonymous about sex differences. So I actually, sorry, were you gonna, was somebody talking?
I was saying, go ahead.
Okay. Okay, I actually just came to this talk from a talk that's happening at the University of California, San Francisco on sex differences in autism today. So I think there is a lot of research happening looking at females with autism and any differences we might see in the diagnostic characteristics across males and females to ensure that we're appropriately identifying girls and women. I think that we're not going to end up having a completely different set of diagnostic criteria for females. The same broad categories of characteristics of autism apply to males and females. We sometimes are seeing a little less frequent or intense repetitive behaviors among females compared to males. there could be at play some bias or lack of awareness of autism that might apply more to females than males just because of the known sex ratio being higher for boys, where I think we need to do some work to find out, are girls showing up with the same symptoms or issues but not getting referred versus boys. So those are some more policy or kind of training issues that probably need to be addressed. At this point, I don't think there's evidence that the diagnosis is vastly different in females compared to males. So now we need to look at, are the tools equally effective? Is the awareness there for identifying females?
Thank you, Dr. Essler.
Sure.
And we're looking through these, just a few more. And so the next one I see is, and Amy and I can probably answer this together. How can we better train medical students to identify IDD, intellectual and developmental disabilities? Does anyone have resources on best practices? If so, please send. And so I was summarizing it. I mean, a couple things I will take from the Learn the Signs Act early, and then I'm going to let Dr. Essler answer it as well. And these are more general, and this is broader than intellectual disability, but some things that we've seen historically in the ADAM data that have been a bit of concern is this ongoing later age of identification, but parents had concerns early, or someone had concerns early. We see documented concerns in their records earlier. And one thing we hear is that sometimes parents aren't listened to, that sometimes if parents have concerns, they're told things, and this pertains to all sort of neurodevelopmental disabilities, autism, and intellectual disabilities, that, he's a boy, he'll talk later, or perhaps a dual language. I mean, there's lots of things we hear from families. So one, listening to families. The tools that we have, and I encourage you to check them out, in the Learn the Signs Act really talk a lot about how to have that discussion. It also, if we have sort of a culture of regularly monitoring development, then we can talk about it with our healthcare provider when we have concerns. But I guess one thing that comes out to me is listening to parents. Teachers play an important role in this too, often are ones to identify. Amy, from a diagnostic perspective, would you like to share? And this question really was about IDD. A little more broadly.
Yeah. I think, there's a broader recognition, like you said, of the need for training our medical students on identifying and screening for different developmental disabilities early in life. And, for a long time, we've had guidance on specifically identification of autism in early childhood and in primary care settings. So I think you could probably do a good PubMed search to look at, pediatric training programs for identification of disabilities and see what I know the literature best on autism. And what that suggests is that you can often get increased compliance among primary care in terms of giving screeners for different conditions, but where it breaks down is the referral. So doctors may increase, their use of screeners, but when the screening comes back positive, they aren't necessarily referring. And then there's also barriers there. If they refer and there's no place to refer to, or the wait list is 4 years long, then you're disincentivized to refer. So I think it's pretty complex, and there've been some good studies on that area and some good work. And I feel like just working in the medical school that there is increased value and recognition placed on the need for specific training in that area. Jen, we did get a question from Kim Hicks about how are multiracial children counted in the demographics. And we had our epidemiologist, Jeanette, weigh in. So the race categories are determined based on the US Census bridged race data. So what the US Census does is it turns many race categories and multiple race into one set of race ethnicity categories. So we're using basically US Census methodology there. When we will present data in early 2022 on Somali and Hmong children, we identify them through looking at language spoken in the home.
Thank you. Thank you for answering that, Dr. Essler. I am just looking at the time and we have about a minute left and I'm skimming the questions. Thank you for all of those. We won't get to all of them today, but one highly pertinent one that I saw that we can answer quickly. Libby, are you able to share the chat seems to be disabled, the MinAdam email address? If you have additional questions, please feel free to contact us at, here it is, everybody. I know this isn't the best way to, you can see that, I think, but autism@umn.edu, all lowercase, autism@umn.edu. And feel free to reach out to us. We would love to share our materials with you and have you help with outreach. And I just wanted to close this out today. Thank you everyone for coming. Thank you for your partnership. We greatly appreciate it. And please reach out to us and look at our website soon. You will see updates as well as we have your email so we can follow up with the recording of this. So thank you so much. Have a great day and feel free to reach out to us with further questions. Take care.